Hello, everybody. Welcome to our second installment in a series here with our Neurosciences department at Boston Children's. Last time we learned a lot about traumatic brain injury, and today we're going to learn about epilepsy. And we have three wonderful guests today. We have Bridget, who is a longtime patient with Boston Children's, and we're going to hear from her about her experience and journey at BCH. We have Meghann, who's been with the program now for a little bit over 5 years, who's a social worker for the epilepsy program. Welcome to both Bridget and Meghann. And we have the privilege of having Dr. Phillip Pearl here, who's the clinical director of the epilepsy program at Boston Children's, has been here for a decade. Came to us from the NIH and trained here at Boston Children's. I won't say how long ago, but he's back in Boston and leads the program. And so I'd like to welcome all three of you today and spending some time with me, who is I am by far the least knowledgeable person about epilepsy, but looking forward to asking some questions and learning a little bit about the journey that patients and families have and where we are in treatment and how that's evolved over the years and what the science is telling us, Dr. Pearl, as far as what might be in store in the future in the treatment of epilepsy. So why don't we get started? Bridget, why don't we just start with you? If you could share a little bit about your journey here at Boston Children's, how old you were when you were diagnosed, and you live in Western Massachusetts, and how that works for you accessing our services and the kind of support that you get from BCH and the program itself.
Sure. Yeah. So I was diagnosed at 3 years old in 2004, and I'm 22 now. So I've been with BCH for 19, almost 20 years. And so I recently graduated from Emmanuel College in May with a biology degree.
Isn't that where Meghann went to undergraduate school as well? Did you know that, Bridget?
Yeah, it is.
Okay. All right.
Yeah. And so I've just been volunteering with the hospital and the neuro department for a number of years now. And I would say, like you said, I do live in Western Mass. And so definitely over the years, my parents and I made a lot of trips into Boston. And I've just had a wonderful experience with Boston Children's, and I'm really excited to be here.
Oh, thank you, Bridget. And when you were at Emmanuel, you were just across the street. So that made it a little easier for you to access our services here, correct?
Yes.
Well, so thank you for sharing that with us, and we'll have the opportunity to talk some more. Dr. Pearl, as far as the diagnosis of epilepsy goes, and if we have any parents out there that have children that have been newly diagnosed, or any patients themselves that have been newly diagnosed, how does that happen, and how has that sort of changed over the years for patients?
Thanks, Dick, and thank you, Bridget, for appearing with us, and thank you, Meghann, for joining. I think it's something that we have dedicated social workers just for epilepsy.
Yes.
That's of historical relevance I'm going to get into, because the diagnosis of epilepsy is essentially based on a combination of the history and the EEG. And epilepsy is kind of a funny term, isn't it? I mean, it's not a tangible. It's more a concept. It's more an idea that you're predisposed to having seizures, which are electrical storms from the brain. And before EEG was discovered in around 1900s to teens, it was purely a clinical diagnosis based on what people saw. And in the times of Hippocrates, since the time of Hippocrates, physicians have had to counter the notion that it was a sacred disease. But by that, it was meant that it was a curse from the devil. The stigma associated with epilepsy has been the most challenging part of it for persons with epilepsy, not just through the last century, but through all millennia, story after story. The modern concept of epilepsy began in 1850, 1860, midway through the 19th century, when very famous neurologists in England at the Queen Square Hospital discovered that seizures come from neurons or the brain, and you could localize a seizure based on what the patient did. Like if one arm twitched, you could localize it to the opposite side of the brain and the motor cortex. But it was really in the 19 teens and 20s and 30s that William Lennox here at Boston Children's Hospital, along with Albert Grass and others, started using EEG. In fact, the first seizure unit in the world was begun by William Lennox at Boston Children's Hospital right here in the 1930s and 40s. And the seizure unit was not only the neurologists, but it was the social workers, psychologists, dietitians, because we were using the ketogenic diet even back then. And the EEG technologists, this is where it all started. So even now, a lot has changed. The medications, the initial medications for seizures were bromides, which worked, but they were so toxic, it was unbelievable. Of the modern anti-seizure medicines, the first one that was discovered and started was phenobarbital, 1912 or so, and then was phenytoin or Dilantin, which a lot of people have heard of. Now we have about 3 dozen medications we use for seizures. But quite frankly, the diagnosis is still the history, which is the patient's story, coupled with the EEG, now the family history, because genetics, like everything else in medicine, represents a lot of the transformational research and future where we are with epilepsy. But the diagnosis remains the history, the person's story, including their family history, and the EEG, the electroencephalogram, because that measures the electrical activity of the brain. And a seizure is an electrical storm coming from the cerebral cortex, or in other words, the neurons, the nerve cells that constitute the gray matter of the brain.
Phil, Dr. Pearl, do you mind, and maybe Bridget, you can help us here because I'm assuming you've had many EEGs in your life, but the actual procedure itself is how does that actually happen, and how long does it take, and what should people know about the actual procedure itself?
Well, I guess Bridget can tell us the patient experience, but it's really nothing scary about it. I mean, we do some pretty fancy things these days, including invasive EEG, where we put needles inside the brain. But in general, we're talking about the scalp EEG, where a neurophysiology, or we call it electrodiagnostic technician, basically the EEG techs, take these little cups, these silver nitride cups. But anyway, and they paste them onto the scalp. There are now more and more
I've seen some of those. They almost look like bathing caps that you
there are more and more
right?
caps that are being used, but for now, this traditional EEG is still where we essentially paste the electrodes on the scalp, and we ask the patient to just relax, even take a nap, because we want to record the brain in the awake state and the sleep state. We do a few other things like shine a flashing light, because that can be informative. We ask the patient to hyperventilate or overbreathe for 3 minutes, because that can be informative. Sometimes we ask the patients to stay up the night before, so we are sure to get sleep, but not always. But essentially, the routine EEG is about a 30 to 60-minute procedure. On the other hand, we do a lot of ambulatory or home EEGs, where patients can wear them in their home environment for several days at a time, which can be informative. And of course, we do a lot of prolonged video EEGs in our hospital facilities.
Great. So, Bridget, how would you describe the patient experience about having EEGs? And you've been with us for a while, so maybe you can even describe what it was like as a youngster to what it's like now to have an EEG.
Sure. Yeah. So it's definitely an interesting experience, but I think, you just kind of have to relax, and the EEG tech will come in and they'll have like the leads, what they put on your head, and they will
Do they
just
have
kind
to
of
shave any hair to do that?
No, they don't.
Okay.
And
just for people that are out there that may wanted to know if that had to be part of
yeah, that's a really good question to ask. No, they don't shave your hair. And then they will kind of map out where on your head they're going to put all of the electrodes, and they will take the glue and just kind of stick it to your head. And you just have to relax, maybe like Dr. Pearl said, take a nap, watch
no
a
pain
show.
involved, right? No pain.
No pain. it just feels cold when they put it on your head. That's all. And the glue smells a little bit, but you get used to that. It's just it's all part of the experience.
Bridget, how often do you have an EEG, or how often did you have them growing up?
Yeah, so for me, my epilepsy was a lot more severe when I was younger. So I would definitely say I had more then compared to like how many I have now, but that's just my specific situation. It's
Yep.
really a case by case basis. But really it's just whenever your neurologist is looking for the EEG data that you'll have to go in and do that.
So, Dr. Pearl, is that something, depending on where someone is in their journey, that happens more frequently at the beginning, or is it something that gets checked on annually, or if symptoms arise again, or there's a spike in seizures? How do the clinicians decide when and how many of those EEGs to do?
Yeah, that's a really good question. And like Bridget said, it's individualized. And it really depends on how the child or the adolescent or the adult is doing. And epilepsy changes throughout the course of the lifetime, and it can be outgrown, especially during puberty, but it can also get worse sometimes during puberty. And then there are other factors, such as the menstrual period for a woman. It can be a trigger. And a lot of patients say stress is a trigger, but that's actually hard to quantify. And also sometimes when we're making a decision about whether a patient can come off medication,
Mm.
an EEG to see how things are going. So even when things are going great, like in Bridget's case, there still may be EEGs, especially if you're going to make a change in the treatment.
Okay. So Molly, excuse me, Meghann, we've allowed you to listen to this for a little bit, but you have an incredibly important role. And Dr. Pearl even mentioned that we had social workers involved decades ago in the support of our patients and families in the epilepsy program. What is a day in the life of Meghann like as a licensed clinical social worker in the epilepsy program?
Yeah, that's a great question. It can definitely be very variable. I think our clinic is very busy. And I think both Dr. Pearl and Bridget have highlighted how epilepsy can be really personalized and very kind of case specific. So the needs of a patient or family, I don't see like two of the same cases in a day. Often it's such a variety of needs. So I may be getting, providers coming into my office asking me to meet with patients that they're seeing in clinic for support with mental health, coping, school advocacy, or even just kind of basic needs. So helping families to access housing, food, or, my co-social worker and I follow patients on the inpatient side as well. So if they're working up for surgery or initiating a keto diet, we might be over there, meeting with families, checking in with them, assessing if there's anything that, might be a barrier to care or things that we can be helping them with. And then we have our families also that kind of stay with us, ongoing. And so we may be answering calls from them or they may be reaching out, or we may be talking with community providers too. So we talk with therapists, we talk with schools. So it can be really all over the place, and kind of what I'm doing from 1 minute to the next can really vary.
Okay. Meghann, do we have parent groups at BCH in the epilepsy program? And how does that work?
Yeah, so one support that we have is the Neuroscience Family Advisory Council, which is neuroscience wide, so not just epilepsy. We're not currently running a specific group for caregivers, but we work really closely with the Epilepsy Foundation of New England, and they run a variety of groups. So they run groups for caregivers, groups for patients of varying ages. They even run groups for siblings. So we partner very closely with them. Sometimes we have a volunteer in our clinic actually that is kind of a bridge between children's and the foundation. So they're a really great resource to get connected with.
Okay. Dr. Pearl, what kind of prevalence is there of epilepsy in our population? And you mentioned genetics. And is it true that epilepsy can also be an effect of a head injury as well in life? And so I guess there's a couple of questions there. What's the prevalence, and can can it be from a life experience as well, not just genetically determined?
Yes, right. You know, epilepsy has a prevalence of about 1.5 to 2% in the population. Although it turns out we all have a 10% risk of having a seizure in our lifetime from something like a head injury at the time called an impact seizure, or hypoglycemia if your sugar gets too low, or just high fever as a young child called a febrile seizure, which doesn't in and of itself count as epilepsy, or being exposed to exogenous substances or drugs or toxins that you end up having a seizure at that time, or being on drugs or alcohol chronically, and then you withdraw and your brain wants that tranquilizer and it's not there and the brain seizes. It's called an alcohol withdrawal seizure or a drug withdrawal seizure, or a direct effect of drugs, especially something that's a stimulant such as cocaine. So there's a 10% chance that any of us will have a seizure in our lifetime, but there's about a 1 to 2% chance that we'll have epilepsy. In the case of a head injury, as you mentioned, Dick, there's a certain chance that anyone can have a seizure after a significant head injury, even a closed head injury with a concussion, or certainly an open head injury where something goes inside your head. And if you have a seizure at the impact, it's called an impact seizure. If you have a seizure within the first week, it's called an acute post-traumatic seizure. But if you have seizures after a week and it's from the head injury, and sometimes they don't start, in fact, often they don't start until 12 to 24 months after the injury, we call that post-traumatic epilepsy. So there are a lot of acquired causes of epilepsy. Epilepsy is most common in the very young, first 2 years of life, and the elderly, because in the very young, there are a lot of issues related to congenital issues or sometimes complications around the perinatal period or childbirth, or genetic issues that present often in the first 2 years of life. And then in the elderly, because the elderly acquire problems such as strokes, say from high blood pressure, or Alzheimer's dementia, which is really the scourge of our modern times in neurology, is Alzheimer's and related dementias. And those patients can develop epilepsy as well. Even though it's not an epilepsy, it's dementia, they can develop epilepsy. So it's most common in the beginning and the end periods of life. On the other hand, so those are acquired for the most part, although I mentioned genetics. On the other hand, there are genetic influences and there are genetic causes of epilepsy. We're going through a transformation right now, frankly, in our culture. One is because of AI, artificial intelligence, which is changing the landscape of medical care and research, although it hasn't quite hit us yet in a way that it might. Another is social media. I feel like we live in a whirlwind because of social media and the positives and very significant deleterious negatives of social media. And the third, now you're getting my philosophical view of life. The third is genetics, the mapping of the human genome. And because of that, we are discovering the genes that cause some of the most severe epilepsies. They tend to be monogenic, which means a single gene is abnormal, or a child has an autosomal recessive disorder, which means they inherit an abnormal copy of the gene called a pathogenic variant. It used to be called a mutation from both parents. But anyway, those are genetic causes of epilepsy that we are now identifying one after the other, leading to the potential, and this is the transformation, for personalized therapy or gene therapy targeted directly at that person's genetic defect. In addition, a lot of the epilepsies that we don't understand are what we call multigenic, which means there's a genetic predisposition, runs in families from probably multiple genes and gene modifying factors known as epigenetics that are at the heart of the epilepsy. So the genetics is complicated, but the mapping of the human genome and the transformation of how genetics is affecting healthcare and leading us to personalized medicine was especially prominent in pediatrics. These are some of the massive changes that we're living through right now. We're living through it at a point where we don't even know what we're living through. It's going to take history to figure out where we're going to end up on the other side of this revolution that, again, I think is threefold: artificial intelligence, social media, and genomics.
Dr. Pearl, how involved is Boston Children's in the research that you're talking about when it comes to epilepsy and seizures and some of the mapping of the human genome? And who are the people at BCH that are involved in that? And how far away are we, do you think, from some revolutionary results?
Well, Boston Children's is very involved in all of this research. I don't think there's another place in pediatric medicine that's more involved in this research. I have the privilege of leading our division of epilepsy, which has 26 pediatric epileptologists. And in this division, we have multiple programs. One of the most prominent, referring to what we're talking about, Dick, is the Epilepsy Genetics Program. This is led by Dr. Ann Pedori. And we have several physicians and fellows and support staff all working in the care of children and research for epilepsy genetics. And in her lab and other labs right here at Boston Children's Hospital, they include in our epilepsy program, Dr. Alex Rotenberg. They're working on gene therapies for these monogenic epilepsies that I mentioned. They're tied into Dr. Christopher Walsh, who runs our genetics and genomics program, clinical and research. Dr. Tim Yu, who's doing a very interesting form of gene editing called antisense oligonucleotides. There are a whole bunch of labs here, and I've just gotten started. Dr. Mustafa Sahin here on our Translational Neuroscience Center. All of these people are coming together, multiple programs and divisions and institutes within Boston Children's Hospital.
That's wonderful.
Working toward this goal of personalized, targeted therapies for at least the genetic epilepsies that we've been able to attribute or ascribe to particular genes. And then it's just going to build more and more from that. But Boston Children's Hospital is a little bit like an onion. Once you start peeling, it doesn't stop. The depth gets deeper and deeper and never stops. And we have the same going on here in epilepsy.
We're going to come back to that in a minute, but I'd like to hop over to Meghann for a second. So Meghann, when there's a newly diagnosed patient and family or guardian that comes into our program, help some of our observers right now perhaps understand sort of how does that day or how does that first initial sort of interaction go, and some of the things that you're able to help and guide families through as they enter BCH.
Yeah, so usually my co-social worker Chris and I will try to look out for families that are coming to clinic that say they're a new epilepsy. So we try to proactively introduce ourselves just so they have that point of contact. But often, sometimes providers, after meeting with the patient and giving the diagnosis and kind of giving the clinical side of things and what that means, they'll refer the family just automatically to social work. They'll explain to the family that the program has a lot of supports, including, nursing and social work, and that they'd like social work to reach out just to introduce. And so then Chris or I will either meet with the family or we'll give them a call, and we'll just kind of check in and see how they're doing, validate the fact that this has probably been a whirlwind for them. It's usually been a bit of a traumatic few days, depending on, how they ended up with us. And then we kind of give an overview of the fact that there are resources and supports available. And things to think about depending on their child's age would be, keeping an eye on how they're doing in school, keeping an eye on their child's mental health, really giving kind of an overview. And then if parents have specific questions, we'll get kind of deeper into things. But we try not to overwhelm with information because it can be just such a onslaught of things in those few days, but we really try to make the connection so that families can reach out to us when they have a minute to breathe and can kind of think about, this might be something that would be helpful.
Yep. So Bridget, let's come to you for a second as we talk a little bit about care teams and your experience at Boston Children's. What I'm sensing is that you may have had the opportunity to be with a social worker, perhaps a nutritionist, right? A mental health provider that's there if necessary. How has that sort of worked when you have a multi-specialty group of folks that come together to help you and treat you as a whole person as a patient in the epilepsy program?
Yeah, so I've had the pleasure of working with both Meghann and Chris over the years, and they've been fantastic, helping me and my family get connected with different resources and just kind of being there to talk about like what's going on with my seizures and my life. And unfortunately, I've never actually met with a nutritionist because I'm not on the keto diet, but I've heard really great things. And I've just had a really great experience with the whole neurology department in general. My neurologist, he's great.
You can go ahead and say his name. It's okay if you say
I
his
can't.
name.
Okay. Dr. Livingston, he's been great. And I saw someone else over the years too, but he's retired now. So,
Okay.
but yeah, it's just been great. And everyone that I've met is just so friendly and helpful. So
Well, thank you for that, Bridget. Dr. Pearl, maybe one of our last questions. You mentioned a whole lot of researchers, some that are within the neurology department, some are that are related in their work. And you mentioned, epileptologists, some of whom may be more clinically focused than others. How does that knowledge come together? And how are discoveries that are happening in the labs and in clinical research, how are they informing the clinical treatment plans of the epilepsy patients?
In general, Dick, there are 3 levels of research in medicine. The way I see the world: basic, translational, and clinical. And we have all 3 going on right here at Boston Children's Hospital, including with a focus in epilepsy. And some of our clinical epileptologists are devoting their careers to carrying out the clinical trials of these diagnostic and therapeutic interventions applicable to patients, directly being translated. By translate, we mean going from the bench to the bedside, and sometimes translating back to the bench or the animal lab to do further research and push the boundaries of knowledge, with the goal of applying that knowledge and applying those studies to our patients. We have a historic epilepsy monitoring unit and a very essential epilepsy surgery program with lots of new technologies in that sphere that we hadn't had an opportunity to touch on, and a whole diet program, the ketogenic diet, and we even now have a keto kitchen program where our professional chefs are demonstrating the recipes and the food preparation. But to answer your question directly, we are at the fulcrum right here at Boston Children's of delivering these new targeted, personalized, gene-related therapies to our patients. And it's our goal to develop them here at Boston Children's and bring them to our patients.
Thank you, Dr. Pearl. Maybe Meghann and Dr. Pearl can answer this. As you become familiar with the patients and their families, what geography do we typically see patients from? And are there people from outside of New England that may come here for a consultation, a second opinion, some specific service that we may offer? How far does our epilepsy program reach regionally, nationally, and perhaps even internationally? Who wants to go first? Ladies first, Meghann.
All the things. We get patients from all over. Because I think, as Dr. Pearl had highlighted with the research, I think there are some rare conditions that our providers are able to treat. So we get patients from across the country. We get patients from outside the country. I've worked with patients from Poland, from the Middle East, from Bermuda. So it kind of really, I think people just come to us for answers, and they come from anywhere.
That's wonderful. Dr. Pearl, how much, how does that get spread, right? As we have patients coming from everywhere, is it the reputation of the research? Is it the reputation of the epileptologists? Now that we live in this technology-filled world where people can do searches on the internet, is it the referral of physicians that know about individual providers, or is it all of those things that is leading patients and families to BCH?
Yeah, it's really the reputation of Boston Children's Hospital, and there's a lot of word of mouth too from, we've been training physicians here for not just years, but generations. So those physicians have gone out and had very prominent roles themselves all over the country and all over the world. We also have quite a few international quite a lot of international physicians that we train. So they're sending patients from all over the country and all over the world. And then there's always word of mouth. But one of my favorite stories is we have a young man that I was seeing from China, and he was seen at Beijing Children's, but he ultimately came here and had surgery for his epilepsy, which was terrible. And now he's been seizure-free for almost 10 years since the surgery.
Hmm.
But my favorite part of the story is he's applying only to colleges in Boston because he's ready to go to college.
That's awesome.
He wants to be here because he feels like his life was saved here, and he just wants to be here. If only my own daughters would listen to him and apply to schools in Boston. Of course, when it's your own children, they may want to go far away. But we know this is a destination for lots of people, especially it's the medicine and science hub of the universe. But it was especially poignant when you asked about international patients that I was asked by my patient in China to just recommend him to colleges only in Boston so he can be here for his own education.
Yeah, that's wonderful. I would imagine over those long periods of time that you care for and get to know patients and their support systems, that you develop very close relationships with people. Meghann and Dr. Pearl, I would imagine that's true. Is that correct?
Well,
Yes.
that's the biggest part of the privilege of
Yep.
being here and in this position and in this profession for Meghann, myself, and everyone else working in this environment.
So, Bridget, I have one last question for you before we talk about Dr. Pearl's famous piano skills as a very high-level pianist, and he keeps his keyboard right behind him. I'm going to ask him a little bit about that. But, Bridget, what kind of advice would you have for younger patients and their parents if they've been newly diagnosed or if they're new to Boston Children's? What kind of advice would you have for them so perhaps they can be a little bit more ready for what the experience might be or questions they might want to ask, or just using your, what's it, about 19 years that you've been with BCH? And what kind of advice would you give from the patient side?
Two things I would say, to stay positive and just know that there are treatments and therapies and resources that you can be connected with here, and just know that you're in the right place and that you will find help here. And then I guess my other thing would be to feel, empowered to ask your doctor questions and feel like you can connect with your care team, and just don't be afraid to do any of that, because at the end of the day, it's your health or your child's health, and that's a very precious thing. It's incredibly important. So feel comfortable to do that, because everyone here will be very responsive.
That was beautiful. Thank you for that, Bridget. And thank you for having the courage and transparency to share a little bit about your story with us and the experiences that you've had. And out there in Western Massachusetts, I hope if you make your travels back here about an hour and a half or 2 hours east, that you don't encounter any snow in the upcoming month, and that ride is safe for you. Meghann, thank you so much for what you do across the board for all of our patients, their families, guardians, support systems, accessing support services and services for all of them, and for your dedication to population of our epilepsy families and patients. And Dr. Pearl, you did a wonderful job of explaining so much about epilepsy, its history, and where we're headed in the future, talking about the diagnosis. But I want to spend the last minute here talking about your skill as a pianist. So how long have you been playing the piano, and do you play the keyboard in your office? And does everybody in the department get to listen when you're taken for a moment and decide that it's time to play the keyboard a little bit?
Well, I started off on drums at age 6. My dad was a professional jazz musician, and my older brother, played trumpet like my dad. So I was like the dummy who only wanted to play drums. But then I expanded my horizons to xylophone, marimba, vibraphone, and percussion. And I grew up in Baltimore, ended up at the Peabody Prep, because my local music teacher said, you got to send this kid down to Peabody. And then Ended up studying at the Peabody Conservatory and Johns Hopkins, growing up in Baltimore. Eventually, I now play professional level piano, vibes, and drums. And we have a town hall every month. And at the end of the town hall, no matter how bad things are going, I try to play some theme music. This time of the year, it might be autumn leaves. The holidays are coming up. People like to hear my favorite things from The Sound of Music.
Mhm.
In the July, it might be summertime. And in June, I always play They Can't Take That Away From Me, because that's when the residents are graduating and no one can take your education away from you.
Oh, that's beautiful. We might have to invite you to a department head meeting or an open forum, perhaps, to display your skills for all of us to see. Meghann, as someone who's probably had to listen to this several times, is it fun?
It is fun, actually. It adds a nice little kind of reprieve from stresses, you know. But what I wanted to share is that we also have a piano in the Fagin 9 elevator lobby.
I have seen the piano, yes.
Patients will play, so sometimes you can hear from the lobby patients playing, but also Dr. Pearl will stop by and play us a tune, so it's fun to have that too.
Oh, wonderful. You are all describing a wonderfully supportive environment for our patients and families and your colleagues within the epilepsy program and the Department of Neurology. So again, as we say goodbye, I want to thank everybody for participating today. Thank you for your time and sharing a little bit about what you do and your story, Bridget, and wish you only the best, all three of you, in your journeys and your work and the commitment of your adult lives to the care of patients with epilepsy and to the support of the science and advancement in the field. So thank you very, very much. And we'll look forward to our next installment down the road. But this brings us to an end today. And I want to thank you. You all did great. I want to tell you that. Okay. Take care.
Thank
you.
You too. Thank you.
Bye.